It's my distinct pleasure to introduce a mentor, a colleague, friend. People online, can you please mute yourselves? Thanks. A mentor, colleague, and friend, and a really internationally renowned researcher in gram-negative resistance. Someone who, you know, is a thought leader and also an incredible sort of researcher. Robert is truly a triple threat with regards to, I was gonna make a joke, but I think of three other things, but in terms of a very active and dedicated clinician, a true educator and mentor, and also just a world-class researcher. Robert's current title is Senior Associate Dean and Director of Case VA Cares and Distinguished University Professor, Case Western Reserve University School of Medicine. I'll turn it over to Robert right now.
Thank you very much, Keith, for those very kind words, and thanks all of you for, you know, taking time out during your day to listen to this talk. Okay, gotta see if I can advance the slides. Okay, well, I want to first start off by thanking Keith and the Division of Infectious Diseases here for this gracious invitation. I learned so much this morning talking to all of you. It was a real pleasure. And, you know, over the years, I've made a lot of friends and I've worked with a lot of people. And, you know, you can't give a lecture like this that involves so many different things without realizing that all these interactions have been, you know, positive, and they've helped me so much. And I've also been supported by the NIH, the VA, and a couple of pharmaceutical industries. So I used to start a talk about antibiotic resistance with all these complicated slides. And I decided I'm not going to do that anymore. There's just really one fact you have to know. And this is not even from an ID journal. This is from an economics journal. And by the year 2050, it is projected that the increases in antimicrobial resistance will be responsible for 300 million deaths. This is going to cost us $100 trillion. I don't need to show you trends on other graphs or fancy WHO pie charts or anything like that. If this doesn't get the message across that resistance is an important public health problem, then virtually nothing will. So what do? Well, our lab studies beta-lactamases, and we've known about these enzymes since December 28, 1941, in a paper, a letter to the editor in Nature. That was the first time an enzyme was described that could break down the compound penicillin. Abraham and Chain wrote that little article, and it went under the radar because nobody knew about penicillin anyway. But anyway, we found out subsequently that these enzymes called beta-lactamases are very agile at breaking this simple bond here between this carbonyl oxygen and this nitrogen. They break that bond. They use a water molecule to make an inactive penicillinic acid. And the enzymes that do this, called beta-lactamase, because this is a beta-lactam bond, are of 4 different classes. And you know, it's not, this is really creative thinking. They're class A, class B, class C, class D. Very creative, very creative. So they designated these classes basically on amino acid sequence. And this is a very old numbering system designation, but the class A enzymes, the class C enzymes, and the class D enzymes work by a certain mechanism. The class B enzymes work a little bit differently. NDM1 or IMP1 or VIM is an example of a class B enzyme, but I'll show you that even though the 2 metal ions are there and it's mechanistically appearing different than when a serine molecule does the hydrolysis, it's all the same. So to overcome these enzymes, you must understand the mechanism. And a number of years ago, 3 or 4 years ago, Karen Bush and Patty Bradford wrote this very nice review article. And I like to bring this out because I like to show the commonality of how class B enzymes work, just like class A, C, and D, and they all use a water molecule and they're all hydrolases. Here you see the serine enzyme forms a covalent acyl enzyme with the beta-lactam compound, and with the presence of water, it breaks it down. Here you have a hydroxyl group being held by two zinc ions. In the presence of water, it breaks down. Now that these are the mechanisms by which beta-lactamases inactivate beta-lactam compounds. Despite learning about these enzymes in 1941, there are still nuances to these mechanisms that we don't understand. And I will try to show you my personal difficulty with some of these things because they've driven lots of investigations in our lab. And the other part of the equation are the beta-lactamase inhibitors. Now, beta-lactamase inhibitors, here designated as I, somehow they follow a path very reminiscent to the beta-lactam compound. But look here, they get a little bit more complicated. The inhibitors can go through different pathways. They could rearrange, they could come off, they could come on, they could change things around. And it's it's much more complex than the straightforward reaction. And I've told fellows in the lab is that, these inhibitors, they live and die at the bench. The more we understand them before they get released into the clinic, the better off we're going to be able to predict their success, as well as to predict their failure. We are going to have a lot of choices when it comes to beta-lactamase inhibitors. Right now, we have ceftaz-avi, ceftolozane tazobactam, imipenem relebactam, and meropenem vaborbactam. We have 4, and right now, everybody in stewardship is scratching their head, which is the best way to use this, which one should we use? But coming down the road, we have at least another 10 that are coming out there. Taniborbactam and metazobactam, and Professor K has been involved in the evaluation of that drug, and we'll talk about that study. Darulobactam, the ATTACK trial, meropenem naco, oral formulations, a drug that's coming out of India very shortly, cefepime-zidibactam and ertapenem-zidibactam. We have a beta-lactamase inhibitor that's still looking for a beta-lactam partner, and there's lots of scary thoughts coming around there. AVO6 is a avibactam that's in an oral form that's been picked up by Pfizer. So pretty soon we'll have an oral avibactam equivalent. And the last drug, cefiderocol, which is really a class by itself. And I think that's a compound that needs a beta-lactamase inhibitor to keep it going. So we have multiple scaffolds. Some of these are beta-lactam based, some of these are boronic acid based, and some of them are like avibactam DBO based. I think if you just take away nothing from this talk other than this, that the most difficult science will not be which is the chemistry that each of these inhibitors follow, but it's going to be how to best use them. That's going to be the real challenging question, because at the end of my talk, you'll see a lot of these are very, very similar. A little different, but they're very, very similar in how they work and what part they get you. We're going to have to design better assays. We're going to have to design better clinical trials, and we're going to have better stewardship programs to help us use these drugs wisely. Avibactam, a gold standard. I knew about avibactam in 2004. 2004, we had first trip over to Europe to do due diligence with the company that was just outside of Novexel, which was just outside of Paris, France. And they had this drug called avibactam, and they said it was entirely new compound. Well, avibactam really, if you look at it closely and you look at this part of the molecule, and you look at this part of the molecule. Remember, I got a D- in organic chemistry, so you can figure this out better than I can. They look sort of similar, and avibactam really resembles the second bicyclic ring system. So it's got a lot of similarities to a beta-lactam compound, even though they say this is not a beta-lactamase inhibitor of the classic sets. It's an inhibitor, but it's a DBO, making it different than clavcel and tazo. But if you chemically look at it, it's very similar. So why is this compound so good? And, you could imagine, running an experiment on Thursday night, coming in there on Friday, and looking at the fact that you have E. coli with a KPC2, you have an MIC that's greater than 512. And then when you give ceftazidime, a little bit of avibactam, you take that 512 and you bring it down to 0.251. Time for a beer. You know, you know you're going to celebrate that night because you found the winner. And so this has been, you know, this is how this compound has really changed the game. It makes you treat things you can't treat, make them treatable. It works against KPC2, it works against CTXM, it even works against OXA48. Bactam don't, but this one does. So you can start distinguishing. It works very well against AMP-C producers. Not too good against metallo-beta-lactamases and certain really complex acinetobacter with class D enzymes. It fails, but it's a very good compound. Years and years ago, we knew about Taz-Avi. We knew it was a very, very good compound then, but unfortunately, ceftazidime made it to market a lot earlier than Taz-Avi did. And I think it's going to be very, very hard to overcome. And we can talk about Taz-Avi, Avi. I was very lucky to work with Foucault Vandenacker, professor of biochemistry, and he helped us understand how avibactam fits in the active site of KPC2. And when I show clinicians this picture from our paper, everybody, the eyes roll back, what the hell's going on? But let me tell you, if you follow my arrow, you will understand this. And here you have the active site serine 70. And when you get to this red part of the molecule here, right over here, this is where avibactam starts, and this is where the beta-lactamase starts. This is very much akin to this figure. So you see your oxygen, double bonded oxygen comes right off there just like that. Here's your first oxygen that makes that covalent bond. And then you form this cyclic ring system that develops a chair, which is just like this. So you begin to see that, oh, I can see the molecule now. You just have to train your eye. And then you see this red thing here with all these, with this yellow in the middle. That's where your sulfate group is. So what the crystallographer does, he looks at these connections, and the first thing that they say, wow, we can see how it binds. We've achieved our objective. You show this to a clinician, and the first thing a clinician says is, how could I make an even better drug that has even more connections that will achieve even something better than avibactam? And people have, that's how people think of these things. And, it's when we as clinicians look at these crystal structures, we have to ask ourselves why, and we have to ask ourselves, what is the opportunity? What is the opportunity that this knowledge is giving us? And that's why, and that's what's really important. But regardless of that, philosophy, if you will, what are the real world applications? And it was David Van Dyne, who's well known to Professor Keith Kay, who was also on this paper, and others from the ARLG, looked at the real world applications of Taz-Avi. And in patients that were treated with Taz-Avi versus colistin, all-cause hospital mortality at 30 days was 9% versus 32%. You don't have to be a statistician to realize that that's a significant difference. And the other thing I love from this paper, and thanks to Keith and David for doing such really, really nice work, is that when they looked at the colistin group and they looked at the hospital death rate, and they looked at the Taz-Avi group and they looked at the hospital death rate, you don't have to be colorblind to realize that colistin did not do as well as Taz-Avi. Very, very clear from this graphic. And this raises the question that I've, often, kind of spar with people. I say, well, if you have one good drug, it's better than two bad ones. Because if you take colistin with aminoglycosides, colistin with other agents, it didn't do as well as Taz-Avi did by itself. But, a lot of other studies came up. Reclaim 1-2, Recapture 1-2, Reprise UTI, and Reprove. The companies that sponsored this kept going on the same theme, to try to get catchy titles so that you could remember the names of these trials. But what Reclaim 1-2 says is Taz non-susceptible intra-abdominal infection, Taz-Avi was as good as meropenem. Recapture, when they compared it to doripenem, as good as doripenem in UTI. Reprise, also UTI and intra-abdominal infection were proved. This was a much more difficult trial in nosocomial pneumonia. Taz-Avi was non-inferior to amikacin and I'm sorry, was non-inferior to meropenem, and they had the option to use amikacin. So, and a lot of retrospective studies. But, it's interesting, you use an antibiotic and you think this is the best thing till sliced bread until something bad happens. And, resistance, it emerges. It emerges when you don't want it to emerge. But, you have to be clever. The more we invest in trying to understand drugs before they're even used, the higher the payoff. And a decade ago, our lab was working on these mutants of KPC, and we realized that ceftazidime avibactam resistance can emerge as a result of a point mutation in the enzyme. Nobody cared. This was put in a journal that no clinicians read, but nobody cared. So what? Then next thing you know, Ryan Shields and others at the University of Pittsburgh started giving Taz-Avi to renal transplant patients. And guess what? They observed Taz-Avi resistance emerging while they were on therapy. At the same time, we were doing some other experiments, looking at the same kind of phenomenon and finding out that this was very, very similar, but it became really scary that a drug that we had, then it hit the radar, that a drug that we had that was very, very good against KPC could all of a sudden not be so good and be associated with treatment emergent resistance. And that's what led Brad Spellberg to write the editorial in CID about Taz-Avi and carbapenem resistant Enterobacteriaceae, taking a line from Jaws, we're going to need a bigger boat. So what did we do about it? If you look at paintings, by Rembrandt, he has more self-portraits than anybody. He is really, and I don't think it was because he had this love of self. I think he was trying to look within himself to find the truth. And, I think that's a good quality sometimes because, the more you introspect, the better off your mental status will be. So I was plagued by this notion. Why is Taz-Avi resistance emerging? What is the failure here? So we started out, we did a lot of different techniques, and the next couple of slides showed we did expression levels, and we did it with protein, and we did it with mRNA. And expression levels look different with protein, but the same amount of mRNA is made, so the proteins are unstable. Okay, let's look at stability. We did thermal denaturation curves and to see, and yes, the D179Y variant is more unstable. Well, that means the protein is probably not put together well. We went ahead and did protein NMR, and this was like pulling teeth. Very difficult thing to do with a protein this size. And we were able to show that the D179Y variant that gave you Taz-Avi resistant had more disorder than the regular protein. And when you tried to purify, you could see it ran differently. We did some modeling, but nobody believes modeling because modeling is not like the real thing. But we anticipated that the modeling would show that there was a break across an important part of the enzyme. We now went on then next to do mass spec. And at this point, you think, Bonomo, you're crazy. Just give it up. You've been doing like experiment after experiment after experiment. Why you keep chasing this goose? And well, we showed that with mass spec that it's very hard it's a little bit more difficult for avibactam to get on the APO enzyme than it is in the D179Y. D179Y did not get on. Avibactam did not get on that as well. So then we went on to crystallography, and at this time, we started realizing that the mutation that we were looking at, the D179Y that gave you Taz-Avi resistant, was very common in the KPC world. There was at least 1, 2, 3, 4, 5, 6, 7 variants that have it. So this is not, it's independent associations. Very, very important to understand this. And so we went to crystallography, and guess what? There was so much disorder, they were unable to map exactly what the changes were in the omega loop. So even with the best technologies, we had to say, well, it's very disordered. So the next, but that's still, even though you have the disorder, it still didn't explain what was happening with ceftazidime. So we worked with a group in England, and they were able to get a structure of a deacylation deficient enzyme. And we talked about how ceftazidime could be accommodated without any steric hindrance, but it never really gave us an answer. So I happen to be talking to somebody, and he says, I wrote this paper a long time ago. You may want to look at that. So Shahryar wrote this paper about substrate-assisted catalysis, and he postulated in these compounds that don't even look like beta-lactams that it's possible for part of the molecule to activate a water molecule. Why is that important? Well, if you look at the hydrolysis by the P99 or the class C enzyme, how you activate this water molecule really matters. If you take the substrate itself, let's say this is a cephalosporin, and the drug itself activates the water molecule, you can hydrolyze off the beta-lactam. So the molecule itself could accelerate its own hydrolysis. In the counter argument, if you take part of what we call the general base, an amino acid that's in the active site that does hydrolysis, if that amino acid activates that water molecule, then you could take off the compound. So whose fault is it? Is it the compound's fault, or is it the enzyme's fault? But a thing that happens is that you got to remember, if the omega loop is disordered, this important amino acid is not in the right position. So we had a suspicion. So we went back and looked at one of our crystal structures, and we looked very, very carefully. And this is ceftazidime in the active site of one of the KPC mutants that has a Q instead of an E at that position. And we looked at how this nitrogen was, and it says, well, if the molecule is making itself go off, which nitrogen is it? Is it this nitrogen that's on the aminothiazole ring, or is it this nitrogen that is part of the six-membered cephalosporin ring? Again, we went to very, very fancy molecular dynamics, and this was done by a really important colleague of ours that's at the University College of London. Great. He's got a great group of people working with him. We were able to identify that the aminothiazole nitrogen is the one that's the culprit for ceftazidime coming off, hydrolyzing itself. An enzyme is not doing it. It's the molecule itself that's the responsible party for its own resistance. So how are you going to prove it, Robert? You could be FOS, right? So we find an old molecule that nobody uses anymore, moxilactam. Moxilactam is an oxycephin. If you look at this and if you're looking for that nitrogen, it doesn't have that nitrogen. It doesn't have the aminothiazole nitrogen. So if it doesn't have the aminothiazole nitrogen, you would predict that if you had the resistant mutant that could make you resistant to ceftazidime, then it wouldn't be able to do this if it were moxilactam. So here's KPC2, MIC8 of moxilactam, 512 of ceftazidime, very susceptible to Taz-Avi. This is the mutant that's Taz-Avi resistant. Goes from 0.5 to 64/4. Still stays very, very high, but look, it becomes susceptible to moxilactam. Here's another KPC3. So now we're testing all the other experiments going on in our lab this week. We're testing all the different variants against moxilactam to make sure that that hypothesis is right. But what we hope to show is that if you have a drug like ceftazidime and you see resistance in these variants, that maybe you should be using an oxycephin instead of ceftazidime, and maybe that's a better partner. Now, this has got implications for drug design because every other molecule I'm going to show you has got a very, very similar side chain like this. And so maybe we need to change the side chains of some of our cephalosporins to preserve their longevity for these type of mutants. I'm just throwing it out there, just, making a suggestion. But I think that this is something that you can learn from these sorts of investigations. All right, Merovaber. Merovaber is an interesting drug because it's an oxyboronate. The oxygen and the boron are part of the same circle. So that gives a very, very different appearance than the DBO avibactam. Very good drug. Biochemically, it was studied very well against a lot of different resistance enzymes, very good affinity, micromolar affinity, and almost to the level of avibactam. This is one of the studies that Professor K was involved in, the effect of Merovaber versus piptazo. This is the Tango 1 trial. Keith, do you want to say something? Or Tango 1 trial was a phase 3, multi-center, multinational randomized controlled trial. Patients are 18 years old with a complicated UTI. And what they did is that for the FDA primary endpoint, success occurred in 98.4 versus 94, and they got a non-inferiority assessment for Tango 1. Tango 2, again, Dr. K was involved in Tango 2, and this was monotherapy for with Merovaber for CRE, and the patients that got Merovaber had decreased mortality, reduced nephrotoxicity, but there ain't no free lunch. The story that occurred with Tazavi, unfortunately, also occurs with Merovaber. And if you have porin mutations in the channel by which these outer membrane proteins, by which these antibiotics get into the cell, 1 porin increases to 16, 2 porins, 64, 3 porins, 256. So porin mutations, Merovaber, you're going to lose it, even if you don't have an OXA48 present. So there's complications. Mo Yasmin in our lab just recently presented. We went back and looked at Merovaber use in University Hospitals of Cleveland, and found that there was much more Merovaber resistance than we anticipated, creating an issue that maybe we should have studied this drug a little bit better before we prescribe it willy-nilly against KPCs. Imirel. Imipenem was I remember in 1985, the first time I used imipenem in a patient. So imipenem has been around a really, really long time. We were very fortunate that Merck gave us the opportunity to study, and it was very, very good against KPC producing bacteria. Very good. And we published one of the, when you look at the Tazavi resistant KPC bearing Klebsiella pneumonia, the combination Imirel overcomes Tazavi resistant KPC. And we're about to submit this paper. And I'd like to show you the data because it's really impressive. Here you have a KPC2 with an MIC of 8. If you give them Imirel, the MIC goes down to 0.5. Ceftazidime, you know that Ceftaz resistant. Tazavi goes down to 1. Here's your KPC that's resistant to Ceftaz-Avi, goes from here, goes from 1.5 to 5.12. It really gets more resistant. But if you have Imirel there, you can restore susceptibility significantly. So this is a good thing against Tazavi resistance emergence. I think hospitals need to be aware that if they have a patient that's on Tazavi for a while and it ain't going right, maybe you should retest that Klebsiella and make sure you still got the same susceptibility pattern, because resistance emerges quickly. This is the clinical data that came from a lot of those studies. This was a phase 3 trial by Merck. This was published in CID. Again, Dr. K was part of this study. This was a randomized Restore IMI-2 trial, randomized double-blind, multi-center, all-cause mortality, favored Imirel, favorable clinical response favored IMI-REL. So this was had a good, very good clinical introduction out there. Clinicians can be confident of the use of IMI-REL in these difficult to treat infections. Even on a practical side, Lillian Abu, who's a friend of Keith and mine, looked at this down in Jackson Memorial Hospital in Miami. Good outcomes with IMI-REL, but unfortunately, if you have porin mutations or mutations in the outer membrane proteins, you will get resistance to IMI-REL. Efflux does not have an impact with this drug, but porin mutations do, so beware. Now we get into all the stars in the sky, I mean, all the choices that you have. This is a Nacubactam, is an inhibitor that's probably going to be paired with the meropenem. This is an avibactam-like drug, looks just like avibactam, but except that it has an amino ethoxy group on it. That amino ethoxy groups allows it to inactivate penicillin binding proteins like mesalenam and the Wockhardt compound, and the people from Wockhardt call this an enhancer. So this is they don't say it's a beta-lactamase inhibitor. They call the Nacubactam is a beta-lactam enhancer. And when you look at the Taz-Avi resistant strains, here you have 4, 1, 8, 8, 8. Here, Nacubactam by itself gives you around an MIC of 1, and no antibiotic is paired with it. So it has an effect both on the penicillin binding protein and on the beta-lactamase. If you combine Nacubactam with meropenem, you get very, very good MICs. And this may be a combination that hospitals may look at very carefully, because if they have a choice between IMI-REL and Mero-Nacu, right? IMI-REL doesn't give me any penicillin binding protein activity. Nacubactam does. So you would have a penicillin binding protein inhibitor, a beta-lactamase inhibitor, and you also have your meropenem. So you may be getting, in certain instances, more bang for your buck with these more advanced beta-lactamase inhibitors and DBOs. Ceftolozane tazobactam. This is the enemy. See that? That's the enemy. That a lot of the cephalosporins have this side chain, and ceftolozane is a very complicated cephalosporin. Each part of this molecule has a specific function. We don't have time to go through this, but this aminothiazole ring, even though it enhances activity against gram-negative bacilli, can be potentially a liability for drugs like ceftazidime and even for ceftolozane, because I'll show you why. Ceftolozane, very good clinical trial data, non-inferior to meropenem, superior to levofloxacin. Against ESBLs, toltezo was better than standard of care. 74% success rate for carbapenem-resistant Pseudomonas aeruginosa. Unfortunately, the AMP-C of Pseudomonas aeruginosa undergoes multiple changes. You can have a variety of amino acid changes in the PDC, and unfortunately, that really increases the MICs to ceftolozane tazobactam. And I wish was not going to say this, but I think this happens more than we think. And I think we just need to be vigilant that emergence to toltezo resistance occurs more frequently than we want it to. We tried to explain this, and if you look at the conformational dynamics with our friend Joseph Heider, we were able to map how one of the important parts of the enzyme wiggles a lot as a result of that change. Because of that wiggling, it can accommodate the big molecule. And we haven't done the experiments yet, but my guess is that in these toltezo resistant strains that have an expanded active site, it's the molecule that's driving the resistance, not the amino acids protein. This is one of the most beautiful portraits ever made, clearly one of the most revered, but there are other novel beta-lactamases on the horizon. There's one coming out of India. Taniborbactam is being accompanied with cefepime for Venatorex. I'm going to talk a little bit about Bactam. I'm going to mention a little bit about N-metazobactam, the QPX broad spectrum inhibitor, and more. So this is a compound that's being developed by Wockhardt in India. This is cefepime. Look at this aminothiazole ring. You never know. And this is the beta-lactamase inhibitor Zidibactam, which looks like a DBO. This compound works against penicillin binding proteins, also inactivates CSBLs, and also works well against Pseudomonas, also works well against Acinetobacter because it has two mechanisms of action. One of them, it gets at the penicillin binding protein. This drug also gets PBBs like this drug does. So you have two penicillin binding protein inactivators, and this drug inactivates beta-lactamases, so this drug can reach other targets. So it's a smart drug. A long time ago, we were able to show just the compound itself was able to change the morphology of cells, suggesting very strongly that it inactivates the penicillin binding protein. So we also were able to capture visual of this. We did a study with Wockhardt that was published in the Journal of Medicinal Chemistry. We studied Zidibactam, and we studied a derivative of Zidibactam, WCK434, and they did very, very good against Acinetobacter enzymes, very good against Pseudomonas enzymes, very good against KPC. And these are being developed as we speak. I think cefepime Zidibactam is going to be in a phase 3 trial right now. And we hope that when it gets released, it'll be effective against CRE, MBLs, multi-drug resistant Pseudomonas, carbapenem resistant Acinetobacter, and even Stenotrophomonas. So I think cefepime Zidibactam is going to have a role. And I think we're going to be looking for, particularly in complicated UTI and in Hab fat. Now, a drug that's gotten a lot of press is the Venatorex compound, or Taniborbactam. If you look at the structure, it's an oxaboronate, pretty complicated molecule. It's going to be paired with cefepime. Look at that aminothiazole ring. But Venatorex did one better than the other companies. They've developed some oral derivatives here, and they're going to be using this compound, VNRX 5236, to give you, this is the prodrug that's going to be given this, that's going to be paired with ceftabutin. This combination is going to be very, very effective against KPCs and ESBLs. So this is going to be an oral combination. This is going to be an IV combination. But Taniborbactam and cefepime is going to be used for not only ESBLs and AMPCs, but also metallo-beta-lactamase producing gram-negative bacteria. So these are the clinical activity has stood up extremely well. Cefepime, Venatorex against all these different variants. The numbers are all small. They're all single digit. These are all double digit and triple digit numbers. So it's at least 10 times more potent than cefepime, ceftoltezo, ceftazidime. Chris Schofield's lab did some very nice work trying to understand the structural biology of it. I think this is the best figure in that paper. It shows you that it's an oxyboronate compound, Taniborbactam, and Taniborbactam coordinates with the zinc ion, the boron does, and the oxygen coordinates with the other zinc ion. So there's a mechanistic basis by which it can inactivate metalloenzymes. But what does all this mean? Well, in the CERTAIN-1 trial, Keith, I don't think this was published yet, is it? No, the CERTAIN-1 trial is a phase 3 trial of cefepime Tani in treatment of complicated UTI and pyelonephritis. So if I showed you that it's good against all these different metallo-beta-lactamases and all these different serine beta-lactamases, how do you think it's going to do? 661 patients, 66% of them were comprised of, 42% had acute pyelo, 57% had just a complicated UTI. About a third of them were over the age of 65. The overall response was almost 12% at the test of cure visit versus the meropenem group, which was less effective. So it's at least as good as meropenem for in complicated UTI. Sulbactam, durlobactam, or they like to say durlosulbactam. This is basically your Acinetobacter drug. This is going to be niched to Acinetobacter. We were fortunate that we were able to do a lot of the characterization that led to the phase 3 trial. But the important thing to know is that in the ATTACK trial, there were 2 arms. Part A was a randomized comparative study of Sul-Dur versus colistin with documented A-Baumani. Part B was an open label portion, Sul-Dur only, including Acinetobacter. All patients in either arm received imipenem cilastatin. Those that received Sul-Dur, the mortality was 19% versus 32% in the colistin arm. Significant difference. I can go through all the microbiology, but what I decided to do is basically summarize that the patients that were given sulbactam, durlobactam, they had lower mortality, higher clinical cure rate, significantly greater microbiological favorable outcomes compared to colistin. And that shows you more of the same. Now, a new drug that's being developed is a drug called N-metazobactam. When we first started working with it, it was called AAI 101, right? And AAI 101 is very similar to tazobactam. This is tazobactam, this is AAI, and everything to this point is the same. The difference here is that there's an extra methyl on this triazole versus this triazole. So you have an extra methyl group that enhances the potency of the drug and its partner, which is cefepime. And what this extra methyl does to this nitrogen is that it makes it a dually charged compound, what they call a Zwitter ion. Now, Zwitter ion, the reason imipenem is so successful is imipenem is also a Zwitter ion. It has 2 charges on it, positive and a negative charge. And it's the combination of a positive and negative charge to make you neutral so you could get into bacteria fast. So that's the key thing here with this compound. One of the things we found in evaluating AAI 101 is that when we looked at a variety of ESBLs that we had that were SHVs, Piptazo didn't do that well against ESBLs. It just didn't. And I worried about that when we did those experiments because I knew about the Marino trial was going on at that time. And I thought to myself, if Piptazo doesn't do that well, and Piptazo is being compared to a carbapenem, which does very well against ESBLs, are the results almost predictable? Aside from this talk, we found out that carbapenems do a lot better than Piptazo in complicated bloodstream infections, ceftriaxone resistant. We studied this compound and it behaved very uniquely in the active site. It formed a bridge across, and other people have confirmed. I won't bother you with those structural details. But what's important here is that cefepime, when combined with N-metazobactam versus piperacillin, I think the results of this study was to show that actually N-metazobactam was compared not only favorably, but it met a superiority compared to piperacillin tazobactam in these complicated urinary tract infections or people with acute pyelo. And everything that was looked at favored the activity of cefepime and metazobactam. QPX7728, they call this the ultra broad spectrum inhibitor. It maybe inhibits too many things. It may be too broad spectrum. If you can have something that's broad spectrum, we don't like it if it's a beta-lactam. Maybe the fact that it inhibits everything else, it may not be good for the enzymes. Anyway, it's got a very good, we've studied it and others have studied the crystallography of it. We know how it fits in the active site. But the problem, I think, here will be they're going to call it zerobactam or QPX. I think it's easier to say QPX. Very good against bacteria. It also binds to different penicillin binding proteins. The problem is it's going to be very hard to find a drug that's going to partner with this. And so far, we haven't had a good partner that's come forward with the QPX. So we have to see how that's going to bear out. Combination that, Maria Mojica in our lab developed is that we were challenged one Friday afternoon. Dr. Shimamura from Ohio State called us up. She had this kid who had constant stenotrophomonas bacteremia for up to 60 days, despite treatment with a variety of things. She said, Robert, can you help us out? And we said, sure, send us the bug. By understanding the mechanism by which steno becomes resistant to Tazavi, becomes resistant to other beta-lactams, like Astreonam, we were able to come up with a combination of Tazavi and Astreonam that was synergistic. Once we started that combination, the bacteremia resolved. We saved the allograft. And 5 years later, yesterday, I was speaking to Dr. Shimamura, and the kid is still alive. He's still doing well. He still got 5 years later, he still got the transplant. So I said, give the guy a hug for me. What can I say? We were able to study it further. It did extremely well in animal models, and Tom Lodi's just recently published a paper on the phase 1 data. As a shameless plug, in the last couple of minutes, this is one of the compounds our lab is developing, MB076. It's a very good inhibitor of KPC and other serine beta-lactamases. Meropenem by himself, MIC of 32, with MB076 as an MIC of 0.06. If you give it to mice with cefepime, the mice stay alive. So we're hoping that this drug may find an application somewhere. We would like to make an oral derivative of this compound, and hopefully someday this drug can even help patients. Some other inhibitors are being developed in the market. In England, Chris Schofield's group at Oxford is developing these type of compounds that work really well in both MICs and also work very well in animal models. These indole acetates, as they're called, they're also supposed to be non-toxic. So we hope, that the new scene, that these drugs, when they appear on the scene, will be very welcome. Our lab also has another project. I was sharing this morning. We're developing these metallo-beta-lactamase inhibitors, and we've done a couple of derivatives of these. These work very well. Didn't do as well as we wanted in MICs, but now when we put a third ring on it, they work very well against MICs. And we have just got yesterday some time kill data to show that these two compounds are actually very effective against Klebsiella pneumonia containing NDM as a metalloenzyme. So in conclusion, we have lots of choices, 14, maybe more. It's going to be, the difficulty here is not knowing which drug to get, but which one is going to be better for your patient population, which one is going to be better for a particular clinical indication. So even though we have a lot of choices, it's going to be even more difficult to pick something up. There's a nice meta-analysis, and I recommend this to all of you. This is from looking at the pooled analysis of all clinical trials. If you look at Toltezo, Tazavi, Imirel, they're not inferior to standard therapies for other infections, but they have greater clinical success, particularly against the most difficult to treat gram-negative bacteria. And I think their real niche in the hospital formulary is not as first-line therapy, but to hold them back when you really need it. And so the challenges ahead, still a lot to do. Identify the measurable biological correlates of inhibition. They're still elusive to us. We know we can measure some biochemical markers, but what makes a particular combination more effective than another? Still, back to the MICs, back to how it's growing in the blood, those markers are still very elusive. I think the main question is what is going to be their role? And I think you can get a good inhibitor, but finding the good partner is like getting married. it's, if you have a nice partner, then you're going to go far. If you pick the wrong partner with the development of an inhibitor, it ain't going to go far in the clinic. So, we have to figure out what's a good idea when we hear it. And the more and more we apply these fancy tools like NMR, peptide fragments, antibody assays, cryo-EM, the more we'll understand it, because eventually we'll get a better look into the soul of why these drugs actually work. And one of my favorite books when I was, growing up is No Time to Lose. This is Peter Pio's book. This is when he went down and he investigated the Ebola and the Marburg outbreak. He wrote this book about, life in pursuit of deadly viruses. He went on to be a major advocate for the United Nations with HIV. And, I think, our job is a life in pursuit of deadly beta-lactamases. So, I think we need to have forward-looking science for the benefit of our patients that's based on sound theory, and it should be our mandate. And I think we need to marry good hypotheses testing at the bench so that we could get success in the clinic. And thank you very much. And there's 6 minutes for questions. Yes.
Questions.
Yeah.
First of all, thank you for the excellent talk. Can you talk about the challenges in pairing the inhibitor with a backbone beta-lactam? And does it have to do with PK similarities? Does it have to do with biochemical interactions between the two compounds? Or what is it? What are like QPX? What's
the first most important thing, that when you pair it, how low do you get the MICs? That's the first thing, because the lower you get the MICs, we believe that time above the MIC, is the major PK defining parameter. Now, that's all based on the assumption that the drug is very soluble, that the drug is non-toxic. There are a lot of assumptions go into that, but the most important parameter is how low do you get the MIC. The other important parameter is what the right ratio is. You can put a beta-lactam to a beta-lactamase inhibitor. Merovaber is 1-to-1. Every microgram of Merovaber, you have 1 mic. So you're giving patients 2 grams of Mero and 2 grams of Vaborbactam. For Taz-Avi, you're giving 2 grams of Taz and 0.5 grams of Avi. So you have to figure out what the right ratio is with the partner antibiotic. Getting the PK lined up is no easy task. And what you want, see, the thing is that you want to have the inhibitor around as long as you have the beta-lactam around, so that you can actually inhibit the bacteria and allow the bacterial beta-lactamases and allow the beta-lactam to work. So that's the, you got to have sort of matching PK/PD. And one of the lessons we learned with Tazobactam is that Tazobactam actually inhibits the excretion of piperacillin. So, you get higher piperacillin levels when you give Tazobactam. So you have to understand all those, and then protein binding, you never use ertapenem if the albumin is low. Not a good choice. Not a good choice. You should use IMI and marrow because, and those are the things you eventually figure out. But I think the most important is knowing, how low you can get the MIC, looking at the emergence of resistance to the combination and serial passage. It's hard. It's hard.
From the audience here. There's a chat. If someone would, anyone online who has any questions or comments?
What are your thoughts on developing an appropriate, separate from backbone drugs? In a perfect world, Dr. Smoke, that's a great idea in a perfect world. But when a beta-lactamase inhibitor is going to be released alone, you can't just pair it with any beta-lactam. It has to be paired with the right beta-lactam for the effect that you want. It has to be dosed appropriately. I think PharmDs are going to be rich forever if that's the case, because they're going to be telling you how to do this. And it's going to be a complicated situation. I think it's a good idea in theory. In practice, I think it will be very, very very challenging because you can't leave. It's very risky to act like a cowboy. You know, I'm going to put this beta-lactam with that beta-lactamase inhibitor. I'm going to mix them together. I'm going to give it to a patient without knowing what's the pharmacology behind it, what's the best MIC. And then the micro lab is going to have to tell you, we have to set all these different tests up so that you do an informed decision. So instead of giving you a Taz-Havi MIC and a Merrill-Weber MIC, they're going to tell you, compound X with the inhibitor, compound Y with the inhibitor, compound Z with the inhibitor, compound A with the inhibitor. Because if we could use 3, why not 4? So I think it's going to be, it can be done. It can be very challenging. I think stewardship people are going to have to be all over it. The micro lab is going to have to be all over it because you can't let people make willy-nilly decisions without giving them the information to make the right decision for the patients.
Other questions? Come on.
I just wanted to know about Nucabactam that you mentioned, Dr.
Nacubactam.
Bonomo. So the enhancer effect is that Nucabactam employs more penicillin binding proteins and basically blocks them so that the bacteria don't replicate. And are these penicillin binding proteins separate from the ones that meropenem acts on?
Yes, they can be separate. And what Nacubactam does, what Zidibactam does, what QPX, all 3 of those hit. So does Darulibactam, but Darulibactam doesn't have an effect on MICs. All these 3 to 4 new beta-lactamase inhibitors not only inactivate the beta-lactamase, but they also hit penicillin binding proteins. So you're giving another beta-lactam with these, so you're giving 2 agents that target different penicillin binding proteins. So that makes it better. It enhances the effect of that. So it's actually a very smart strategy because I'm giving 3 I'm giving Nacubactam with Mero. I'm actually giving 3 drugs. 2 penicillin binding protein inhibitor and 1 beta-lactamase inhibitor. We've exploited this with Mycobacterium abscessus. We've used multiple beta-lactams with M. abscessus like imipenem and ceftaroline. We get excellent results against M. abscessus using that combination. And, that's topic for another day. All right, thank you.
One more announcement before we go. Tanea, did you want to come up here for 1 minute? And again, I want to thank Dr. Bonomo for his excellent talk. Yeah, just have an announcement. You announce.
It's resident and fellow appreciation week this week. So you came at a great time, Dr. Bonomo. They got lunch today, they're getting lunch tomorrow, they had lunch the other day. And then from our faculty, our day faculty have pitched in to give you a little treat as well. Okay, so just want to share with you. So Dr. Butt wanted to take up
Maybe there.
Yeah. Oh, me.